all to this town hall Q&A. A little bit of background on the Bronx and the Brooklyn Health and Housing Consortium. We are a collaborative network of healthcare, housing, social service organizations and government partners, really working to strengthen and integrate the healthcare and housing systems at the policy level, operational, and individual client and patient levels. So we do that in a lot of different ways. We have a whole training program where we provide training to frontline staff on issues such as, how to support somebody who's facing eviction and prevent that eviction, to supporting someone in rental arrears, and on different health issues on, what do you do if a client has sickle cell? So really just trying to provide information and support to our member agencies and their staff. We also hold interagency case conferences as an opportunity for staff to come and talk about a client or a patient that they have and get feedback and advice from others, and really just sharing information and resources. And that also lets us know what some of the challenges are on the ground that we can then elevate to higher levels and really, see if there's any ways that we can improve the services and the systems that you all are working in. And then we do a lot of different events. We have housing places that focus on different populations and really an opportunity to meet housing providers and find out about eligibility and vacancies and referrals and all of that's really hands-on stuff. And then we have a component of research and advocacy. We've partnered and conducted for the past 6 years a hospital homeless count, going into hospital emergency rooms and counting folks who are unsheltered and homeless there on the same night street and subway census. So that's just a little taste of the work that we do and in general. And obviously things have changed a bit in this new environment post the outbreak of coronavirus. And so we are trying to adapt to an online format, which is not our typical means of doing things. So thank you all for being here and for bearing with any issues that we might have. But we really want to be able to support you all. You're on the front lines doing this work. And we've heard last week we had a town hall where we had a physician who works with people experiencing homelessness, and Dr. Lee Isaacson from Janian Medical Care was able to answer questions that you all have about COVID-19, about how it's spread, about how to protect yourselves. And so that session was recorded. We will be happy to share that around. And then today we are, this is our second town hall, and this is focusing specifically on the Department of Homeless Services shelters and isolation shelters with regard to DHS clients who are either COVID-19 positive or under isolation for, until awaiting test results, and specifically how the process between hospitals referring and discharging clients to their patients into DHS isolation shelters. I do want to just make one point that this is specifically for DHS clients. We know that there have been a lot of questions about what options are available for non-DHS clients. We had hoped to get somebody from Office of Emergency Management on this call to be able to answer those questions. We were not able to, but we are still pursuing that and are hoping to be able to have a dedicated town hall with somebody from OEM to discuss that specifically. So I understand that there might be questions about that. We're not going to be able to answer those questions in this forum. This is specifically about DHS clients. We did just a few logistics before I introduce our speakers. We are recording this session and we'll be sharing it out with anyone who registered. So, once that goes out, please feel free to share that with anyone of your coworkers or who were not able to be on with us live. We're going to ask our presenters to give a brief overview, and then we are going to take questions. So some people had sent questions in advance. We're going to start with those questions, and then if you, hopefully that might address some of the questions that you have, but as we go through, you are welcome to submit questions into the chat box we will be monitoring that, and we will get to as many of those questions as we can. Everyone is muted, so the best way to communicate those questions is through the chat box. Please try to keep the questions as focused as possible. We have over 200 people that registered for this town hall, so there's a lot of people and there's bound to be a lot of questions. So if you can be as focused in your question as possible, that would be much appreciated. Anything that we don't get to today, we will be compiling and we'll send to our presenters. And DHS has said that they will go through these questions and will incorporate any that are common into an agency-wide FAQ. So they're not going to be able to respond directly to independent questions, but they will put out an FAQ with responses to some of the common questions. I think that that's it. I'm going to be turning off my video so as not to be distracting. I just wanted to be able to have a face and welcome you all. And our speakers are welcome to leave their video on or off, and we'll get started. So I want to introduce Dr. Fabienne Laraque. She is the medical director of the New York City Department of Homeless Services. We also have Meghan Smith, who is the executive advisor for policy and operations, also at the Department of Homeless Services, and Dr. Alessandra Calvo-Friedman, who is the medical director of the Social Determinants of Health in the Office of Public Health at New York City Health and Hospitals. So we are so grateful to our speakers for making time for this important session. We know that everyone is maxed out and trying to respond to this crisis that is changing so quickly. So really thank you so much. And with that, I'll hand off to Dr. Laraque. Thank you.
Hi, thank you so much, Bonnie, for this opportunity. We've been working really hard on trying to get guidance out to our shelter, to our hospital. We definitely understand the pressure that this pandemic puts both on our shelters and on the hospitals in New York City. So we started by creating guidance, which sounds like a lifetime away, a couple of weeks away, on isolation, quarantine, and screening those that had symptoms and a travel or contact history. We switched really quickly as the situation changed in New York City to with the assumption that everybody is exposed, to focusing on identifying our clients that have COVID-like symptoms or are COVID positive, and putting them in isolation, and working with hospitals to facilitate discharge and referral, as well as work with our shelters to do that. We work with DOHMH and HNH to both develop guidance for shelters and also put up some algorithm and mechanisms to get our clients either to the hospitals, to another form of testing, or directly to isolation site. And as things change and testing was not available, and the guidance, which is to isolate clients or individual with mild illness and sent to the hospital don't have moderate or severe symptoms, we adjusted procedures. We definitely understand that things change several times, but the situation changed drastically over just a couple of weeks. So in addition to preparing those algorithms, which Meghan will go over in a couple of minutes, we transform our serious incident unit, which was established a couple of years ago, to take reports of serious incidents into a 24 hours hotline for isolation site and for hospitals and shelter alike to contact. This was definitely a work in progress. I know there were bumps along the road, but this is something that we had to set up literally overnight. And my understanding right now is that the hotline is pretty much fully staffed, and that the long delays should decrease. In addition, if the client is at the shelter and they need an isolation site, there is another mechanism that there's an email and another mechanisms that can be used to get them to their isolation site. So essentially, a client can get to our isolation sites, which I will describe in a minute, in various mechanisms, either directly from the hospital, ED, or inpatient department, through calling the SIU, or they could walk in and say they have symptoms, or they could be sent from our regular shelters to the isolation site. Right now we have 4 isolation sites. We have 1 opening at the end of the week and more coming. We have about 500 isolation beds. Those sites, there are 2 in Manhattan, 1 in the Bronx, 1 in Brooklyn for now. They have, so I mentioned how many beds, about 500 beds, perhaps about half are occupied at this point. So we do still have capacity, and we are increasing capacity. Those sites, again, the client are in isolation. They are not, there's no common area. They are told to be in their rooms. They are provided meals and the usual shelter services, not social services, because they are there just for the duration of their isolation. And they are nursing monitoring twice a day, and nursing presence around the clock. So even though only individuals with mild illness that normally would be sent home and self-monitoring without nursing are eligible and should really be in those isolation sites. We, because of our population is fragile, and we have an sense of responsibility, we established nursing monitoring at those sites. I think that's a quick overview of what we are doing. Oh, just one more thing. We have been giving instruction to our shelters about cleaning, about isolation, quick segregation of clients with symptoms. We have provided a mask for clients that have symptoms, and we're also providing transportation to the isolation site. So our shelters have received number of instructions, and we plan to do some webinar for the shelters also at some point. So with that, I'll pass it on to Meghan and wait for your questions in a bit later. Thank you.
If we could pull up the streets workflow, that would be great. Okay, so we have issued guidance. This one was pushed as of Monday to our street and shelter providers, asking and this flow lays out how we are getting clients either to the hospital or isolation. So we ask them to assess a client at the beginning of a street outreach engagement for COVID-19 symptoms. For street outreach providers that have a medical provider, we ask the medical provider to use their clinical judgment to decide whether or not a client needs to go to the hospital, whether or not they have a COVID-like illness. At this point, we're not testing for coronavirus for everyone. And if the medical provider can make the determination that the client needs to just go straight to isolation, they will coordinate with DHS's Serious Incident Unit to go to be transported to our isolation site, or the medical provider can determine that they do not need to be isolated. If there is no medical provider, we ask immediately, is the client stable? If they are not, we ask that you call 911 and get them to an emergency room. For clients that are stable, there are currently some hotlines that H&H has stood up. If it is from 9 a.m. to 9 p.m., you can call the New York City COVID hotline. The number's on the screen. From 9 p.m. to 9 a.m., there's an Amwell hotline that you can call. So those hotlines will have a clinician on the line to walk through symptoms with you and help you determine if the patient can go to shelter, needs isolation, or needs emergent care. Okay. So our shelter workflow, if we can move over to that, follows very much a similar path, that if there is a medical provider, we're asking that the medical provider use their clinical judgment to decide if a client needs to go to the emergency room, or if they can go into an isolation site without having needed to go to the ER. If a medical provider is not on site, it's again the questions about whether or not the client is stable. If they are not, we call 911. If they are, also calling the hotlines and then using that clinical judgment to determine whether the client has a COVID-like illness and needs to be taken to an appropriate DHS isolation facility. Our isolation facilities are for clients who do not have a private setting in shelter, so are living in a congregate shelter where they share their room and our bathrooms. For our clients who are in a shelter that had their own private bathroom and isolated unit, they are being isolated in shelter. So our isolation units are primarily being used for single adults and adult family clients. Okay, so if we move over to our hospital protocol, which DHS worked in very close coordination with health and hospitals on this, we ask when an ER is ready to discharge a patient, they ask the patient to indicate if they are a client in our system. These questions that the hospital is asking are not how we at DHS are filtering clients for whether or not they are in our system. It is more of an indicator for the hospital whether they should be calling us or whether they should be calling Office of Emergency Management for their isolation sites. If the client indicates that yes, they are homeless or are in our shelter system or are street homeless, they're going to call DHS's hospital referral line, or we also call it our serious incident unit. That person answering that question, that hotline will ask 5 fairly quick questions: the patient's name and date of birth to confirm client history. We ask the hospitals to acknowledge that there is very limited medical care. This needs to be patient clients who can do their ADLs and do not need regular routine medical care, because that is not the appropriate level of care at our isolation site. So we need to make sure that the client is appropriate for the level of care that we can provide at these sites. We ask for date of symptom onset, if they have the date of last fever. Both of those questions really help us determine when it is safe to discharge a client from the isolation site back to our shelter system. And then we just ask a very broad question like, is there anything else you as a medical professional want to tell us that we should know about this client before they come into our isolation site? If it's a DHS client, we'll coordinate transportation to isolation. We ask people to recognize that we have transportation contracts in line. We actually have 4 layers of transportation contracts right now. But transportation is a challenge for us. There is some independent judgment that a transportation company may say yes to us, but when that individual driver shows up to a hospital, sometimes they say no. So we have lots of layers of transportation scheduled, but it does often take us anywhere from 20 minutes to an hour to 2 hours to really get transportation there. If the client has no homeless history, we're actually going to suggest that the client is transferred to the Office of Emergency Management isolation sites, and your hospitals will have an authorized point of contact to call the OEM isolation sites and coordinate intake through their phone number. And I think that's it.
Okay, great. And thank you so much, Megan. And we'll just move on, I think, to Alessandra, if she's on.
Sure.
Okay,
Can you hear me?
Yes.
Hi. So my name is Alessandra Calvo-Friedman. We have been working closely with DHS on, as Megan said, on some of the workflows that she showed us, and I just wanted to provide sort of overview of the hospital perspective here and sort of the important points on our end to communicate with everyone. So basically, I think as you all know, our hospital systems are becoming quickly very, very full and overwhelmed. The emergency rooms in particular, as well as some of our inpatient services are, have a lot of patients there for evaluation. And so this iteration of these workflows that we've worked on with DHS have really been to sort of move our workflows to the latest DOHMH guidance around testing. I think, as you all know, previously a lot of people were being brought to the emergency rooms for testing, but given the widespread community transmission, limitation of testing, and sort of need for isolation, about 10 days ago, the DOHMH guidance changed from testing more widely to really just bringing people to the hospital for testing who needed who you think have moderate symptoms who need potential hospitalization. So in order to, to do that, we have put in place these two referral lines for shelter staff and street outreach staff to be able to call with a patient to really get a clinical assessment of whether a patient needs to go to the emergency room or not. So the main sort of decision point for the clinicians staffing the line is, are this patient's symptoms severe enough that they need to actually go to the emergency room for evaluation for potential admission and inpatient management, or are their symptoms stable enough that they can be effectively isolated and stay at home or stay in a isolated site away from other people. And that's both good for the patients and good for the hospital system. We don't want to be transporting a lot of people who may not have COVID to a setting in which there's a lot of sick people around. And we also don't want to be bringing in people sort of unnecessarily to the ED that sort of further overwhelm the ED sites. So the two lines that Meghan mentioned are available for use. The H&H line is staffed by H&H clinicians, and the Amwell line overnight is staffed by a separate group of doctors, but you will get to speak to a clinician to make an assessment. So I think the important points really for us are patients who are coming into the EDs should really just be patients who have moderate symptoms, and that really means sort of moderate shortness of breath. That's some of the main symptoms that would really trigger a need for admission. People with more mild symptoms like cough but not significant shortness of breath, sore throat, should be able to be isolated as an outpatient and not be brought into the emergency room. And then, we've also been working with DHS on the flip side, given the hospital census, and then really, it's imperative for us to be able to quickly and in an organized way discharge patients to isolation from our very busy emergency rooms and inpatient services. So this referral line is a really important piece for us to be able to really have our frontline clinicians be able to contact DHS and get them sort of out of the emergency room and into an isolation site as effectively and quickly as possible. So I think those are the two pieces that I wanted to highlight in terms of import to the hospital system. And maybe we'll go on to questions and anything else that comes up can answer from there.
Great, thank you so much, Alessandra. I think we will jump right into questions. So we have a lot of them. We're going to do our best to get through as many as possible. So first question is for DHS. How are the isolation units being staffed? By whom and how many people to number of clients? And where are these isolation units located? Meaning, are they under a DHS property or somewhere else?
Sure. They are under contract by DHS. We are using the newer providers to open them up. The staffing is the usual shelter staffing for non-clinician, and then there is a ratio of 1 nurse for 25 clients.
I think I want to just clarify, the 1 to 25 is an ideal ratio, and that's what we are shooting for when we are staffing up. There are always medical providers, nurses on site, but we are not quite at the 1 to 25 ratio right now. That's our goal of having staff there.
Okay. Is there any plan for DHS to allow flexibility on their discharge policy of Monday through Friday, 9 a.m. to 3 p.m. for non-COVID patients?
No. We relaxed greatly the criteria for inpatient for the COVID patient. For the non-COVID patients, we are unable to relax the criteria except in certain circumstances. I have been talking to program about trying to allow, and I have allowed on occasion, the weekend discharge. The nighttime discharge are a real problem for shelters. Sometimes there is no one on board. And because some of the clients that are being discharged that are non-COVID can be really ill and medically frail, and because we know that we do get inappropriate discharge, we really don't want to be in a situation where we have clients that are not quite ready or appropriate for shelters and have them discharged. We are reviewing the discharge as fast as we can, and I have instructed at least our staff to review them, and not necessarily, although not that we've been waiting for 24 hours, but to do it as soon as we can, so we can provide the determination rapidly. So if a client can be discharged the same day, that's fine, but we are not able to do that, 24/7 and on weekends.
So kind of a follow-up to that, has anything changed regarding non-COVID-19 patients in admission to shelter?
No, there shouldn't be.
All right. Some questions on protecting people who are experiencing homelessness. Are there any plans to keep homeless folks from getting COVID-19? And kind of as I'll group these together, how best can we care for the health and safety of folks living on the street?
Meghan, you want to start? Go ahead.
Sure. We have been providing alcohol wipes and socks that have been donated to us to our street outreach teams have been handing those out. Hand sanitizer, I'm sure, as everyone knows, is very challenging to get. We have our orders in with emergency OEM to do so, but at this time we're handing out alcohol wipes. Our street outreach providers continue to be in the community, engaging with clients, screening them for coronavirus symptoms, encouraging them to come inside. We have seen an incredible uptake in the amount of street clients that are coming into our adult intake centers. So we are seeing an increase of clients coming inside, which is a good thing in this current environment. So we are continuing to do outreach and providing for the health and safety of our street clients as well as our shelter clients.
And if I can add, we have given instruction to our shelters about, redoubling cleaning, really making a big effort in cleaning and staggering meals, staggering bathroom times, and various social distancing as much as possible guidance in the shelters.
Yeah, and we issued 9 pieces of guidance on Monday. Some of those were simple FAQs to post in shelters in plain language. Some of it was protocol for shelters to run isolation sites. We are continuing to issue guidance and push both things that are directed towards providers, but also to the clients and their staff that are in much more plain language. And we will continue to be issuing that kind of guidance to try and make sure that everyone is aware of best practices surrounding COVID-19.
So kind of expanding off of that for protections for frontline employees, we have a question. Our primary work is going out in the field to conduct home visits, hospital visits, nursing home visits, MMTP, et cetera. How can we protect staff? And just as a follow-up to that, do you have any advice for providers in trying to access PPE, personal protective equipment?
So I'm sure everyone is aware that PPE is incredibly difficult to come by right now. DHS has quite a few orders that we have done independently and also through the Office of Emergency Management. We are very much in the same situation that the rest of the country and our providers are with PPE. At this time, guidance still is not that you do not need to be wearing PPE unless you are directly interacting with an ill client. We are not discouraging people from wearing PPE, but the current guidance is it is still not recommended, and so we are adhering to that. Our isolation sites who are interacting with COVID-like illness patients and confirmed positive patients do have PPE on site for staff.
And if I can add, we have distributed surgical masks to all of our shelters to provide clients that have symptoms. So one way to protect staff is to a mask and isolate clients immediately. So if a client presents with symptoms, they are given a mask, they are put in an office. We don't have isolation room in most of our shelters, but we do have office with doors, so they are immediately separated. Then transportation to an isolation site is arranged if that's the case, or to an ED if they are really sick. We are getting more donation actually of surgical masks, so we will continue to protect by separating person with symptoms.
A few questions about the hotline. So we've had two different private hospitals mention that they had tried to call the isolation hotline number and were told that they are not yet authorized to use the number. Someone from Montefiore as well as North Presbyterian. And another person regarding the OEM beds, asked yesterday on a call with Steve Banks, who were the authorized points of contact, and mentioned that hospitals were unclear on this, and he said he would look into that for clarification because he thought the information had been conveyed. So first question about hospitals having authorization for the hotline number, and then the authorized points of contact for those as well. Sorry, these are specific to the OEM hotline.
So we are not experts in the OEM hotline. We have been involved in communicating with them, because determining which ones of our clients versus go to our shelter system versus what goes to them. I will flag to our contacts at OEM that there is not clarity on who an authorized point of contact is, and that there are some challenges, and our commissioner will also flag it directly to his senior leadership, and we will try and get some more clarity to you all. But at this point, I don't think DHS has the full scope of information to be able to share with you on the OEM sites at this time.
And if I can add on your first questions, was the question that SIU answered and said that this hospital wasn't authorized to call SIU? Can you clarify that?
I believe, yeah, let me pull up the exact question. From a Montefiore social worker, that they tried to call the isolation hotline number this morning, the one that's listed on the hospital discharge form, and we're told that Montefiore is not yet authorized to use this number.
So that's the OEM isolation line. That's not, DHS will talk to anyone.
Yeah. Oh. If they call 212-361-5590, there is no authorization required, we will answer and talk to anyone.
Okay. Let's see. While we're on the topic of the hotline, are there any options, or sorry, not a hotline question, but are there any options to move older homeless people who are vulnerable to severe COVID course into private rooms rather than back to congregate shelters to protect them before they have COVID?
We have heard your concerns, and we are evaluating internally now. Oh, wait, we don't have any definitive policy that we can share at this time.
But yes, definitely, we understand the situation, and we are talking about it internally and weighing various options.
Okay. And also, speaking of people who are higher risk, are persons with chronic illness, such as AIDS or autoimmune illness, at higher risk for contracting COVID-19?
We don't believe anyone is at higher risk of contracting COVID-19, but those that have certain chronic condition and are immunosuppressed would be at higher risk of complication and dying. Just one point, in general, persons who are severely immunosuppressed are not medically appropriate for shelter and should not be in shelter. And for those that have HIV with or without AIDS, they are eligible for HACA, which are private units. So we really highly encourage you, if you have any client that have HIV/AIDS, to really call the HACA line, because they are by default isolated, and they really should not come to a congregate setting.
Are there any protocols or response efforts planned if there is a large-scale breakout in a shelter?
Yes, we are working on a cluster/outbreak procedure. We are in the process of discussing and vetting it now, and hope to put it in place rapidly. Some of the thing, we'll investigate, and we'll have an overall procedure, but we will also plan to investigate and target the response depending on the situation.
There's a long turnaround time for isolation sites to be confirmed, making the arrangement difficult from ED and triage tents. Are there currently any plans to improve turnaround time on DHS transportation to isolation sites? I've heard that hospital providers are experiencing 3 to 8 hour waiting times.
So as we talked about, we have multiple layers of transportation coordination that is occurring. We know that it is a challenge, and it is one that we are continuing to solve for. It is not something that we can solve for overnight, but we are working on it. I think we stood up an isolation site weeks ago, and really sort of with duct tape and glue, and have really systematized and expanded our isolation site and our ability to answer phone calls and be responsive to all of you. But we are still working on expanding our staffing and our transportation contracts and all of that. So we hear you, we are working on it. I'm sure you've all heard this saying over and over again, we're building the plane and flying the plane at the same time. And so continue to provide us feedback. We really appreciate it, but also please bear with us. This has caught us all, we're all in the same position of kind of putting together a process and implementing it exactly at the same time.
Yeah. So as a follow-up to that, are hospitals allowed to arrange their own transportation to isolation sites once the isolation site is confirmed?
Absolutely. The only thing that we ask is that you not send a patient in an ambulance. If a patient needs to come in an ambulance, it probably means that they're not appropriate for our isolation sites. And we've heard feedback from the hotel operators that it really is sort of freaking the community out. So I know that doesn't sound like a great answer, but we prefer that it to be ambulette or some other kind of transportation. Ambulances really aren't appropriate for sending clients to our isolation sites. But if you can coordinate transportation, SIU will discuss that with you, and that will ease some of the time it takes to get the client to isolation.
This is a medical question we have, and I'm gonna try to say these words as a non-medical professional. So people who are taking antihypertensives like olmesartan, which is an angiotensin receptor blocker, should they discontinue the drug if they get affected by the coronavirus?
So I don't know if Alessandra has that answer. As one of the medical providers here, I would say that that's not a question for DHS, and that's a question for that client's medical provider that is evaluating it at the time. Generally speaking, discontinuing any drug would be a probably bad idea, because you would have COVID and a hypertensive crisis. So before discontinuing any drug, that would be really carefully considered by the treating providers. And if they are not comfortable making that decision, then consult a senior medical provider or an infectious disease specialist.
Okay, great. So just jumping back for a second to the issue of transportation. So this is from Montefiore. The hospital policy is that all COVID positive patients are transported in ambulances due to ambulettes not having PPE.
Okay, that's an issue. Thank you for telling us. that's an issue we will need to raise with some of our other contacts, because it is causing challenges with our hotels' willingness to continue to provide isolation sites for us. So thank you for flagging, and we will work on it.
Is there anything, this is for the DHS, is there anything you wish hospitals would know that would help you right now to, or ensure appropriate isolation site placement?
Sure. It's challenging for everyone. We understand the hospital's policy, but also we wish the hospital understand that we are a shelter system and that pandemic affect us as everyone else, and that setting up 24-hour line, 24 hours transportation and isolation site is not necessarily something that we envision or is in our mission. Our staff are also scared, worried, and are also being exposed, potentially. And we really want the hospital to understand that we are also in a difficult situation, and that we are doing our best, and please work with us.
I think also making sure, and Fabienne, you can speak to this better than I can, but making sure that you are sending us patients that can do their ADLs and really are appropriate for the isolation setting, because of the really limited healthcare that we are providing. We are really truly doing wellness checks and making sure that a patient does not need to go back to the hospital, but that is the level of care that we are providing at our isolation sites. So we really want to make sure that everyone understands what kind of setting that they are discharging a patient to.
Thank you, Meghan. That's really, really, really important. We are still a shelter system. We have not become a step-down unit or a nursing home or a rehab center or a mini hospital. And we cannot take care of people who cannot take care of themselves or are really, really, really sick, even if they don't need, a hospitalization. So we have to be careful. This is the equivalent of basically sending someone home.
Can you just let us know, where was the guidance that was published, the 9 pieces of guidance for shelters that was published on Monday?
Sure. So our administrator sends out a blast to all of our providers and medical providers regularly, almost always every Monday, but then at other times throughout the week. We also, on our provider portal, if you are a DHS provider, make that information public. And I believe Greater Hospital Association of New York, as well as H&H, have been pushing that communication to their network as well. We can make sure that other networks are included on those communications as well, to make sure that they are reaching everyone who it is appropriate for.
Yeah, so one of the things that my office does is send communication to social workers and EDs with the shelter list. And unfortunately, my staff who sends this communication regularly was ill with cough and fever and been at home and in bed. She's better today, and one of the things that we want to do is make sure this communication is sent to our contact list. We know sometimes trickling down from Greater New York might take a little bit, but we intend to send it to you guys that we have contact with right now.
What additional services are being offered to unsheltered individuals on the subways? The numbers on the subways seem to have significantly increased as ridership has gone down.
We're continuing to do our shelter out, or our street outreach, both on the streets and in the subways. Our subway outreach teams are still in the subways. We still have our end of line providers, so we are still present as much as we can, given the staffing constraints, with providers having staff calling out sick and all of that, but we are still very much a presence in the street and the subway with our outreach teams.
What's the response plan for encampments and homeless individuals when or if they will be mandated into shelter?
We do not have a policy this time at mandating clients into shelter. So that we don't have any further guidance that we can share at this point.
Question regarding medications. Is there who are high risk to get their medications while at the shelter without having to leave the shelter, exposing them to contact with infected individuals? And part two is, what should we tell patients from a hospital side? What should we tell patients who are worried about getting their medications in isolation sites?
Yes, we have directed the isolation site to assist and their original shelter to assist clients in receiving their medications. So if their medication is at the shelters, then the shelter provider in the isolation site should be working together to get their medications in general. Very specifically, we've been working separately on a client on methadone and possibly buprenorphine also, to get a system with OASAS and the Department of Health and Mental Hygiene to get client on methadone to receive their week or 2 week supply, depending on what they need at the isolation sites.
And anything for those that are already in shelter, who are not COVID positive but are higher risk about getting their medications brought into the shelter rather than having to leave?
So the shelter would need to work with the pharmacy to get the medication delivered.
And we have shared sort of guidance that has been put together in terms of Medicaid, issuing guidance on supply of 3-month supply. I believe it's a 3-month supply of medication. We've been continuing to share any guidance that we've gotten from the state or federal level surrounding Medicaid to the shelters when we have it as well.
So you mentioned previously that those who are not independent in their ADLs should not be sent to shelter. Where should these individuals go who need support with ADLs and are experiencing symptoms?
So just as a reminder, the majority of the clients that we are receiving are those that are current shelter residents. So presumably they can perform their ADL, they have a pneumonia, they go to the hospital, they should be able to come back in the same state. So they will be able to perform their ADL. If it's a completely new person who's never been in shelter, who developed COVID but happen not to be able to perform their ADL and they were living somewhere but they cannot return there, it seems to me that might be OEM questions. If OEM is not able to deal with that situation, it might be a situation where we have to put our heads together and try to figure it out. But normally somebody cannot perform their ADL. It's no different from any other hospital referral. They are not appropriate for congregate setting or for DHS shelters.
If a patient who is homeless wanted to go straight into a long-term care facility, but now cannot because the facility isn't admitting new patients with the virus, how can we help with their housing because they're now homeless? I don't know if that makes sense.
So somebody needs a long-term care facility. They meet all the criteria. They were admitted, but they can no longer go. Can you explain that situation a little bit?
They're finding maybe that some long-term care facilities are not accepting new patients because of the virus. And so what options do they have for those?
I think maybe you need to address that with the state. I mean, yeah. It's a nursing home. It's a nursing home question. So it seems to me that if they need nursing home, independent living is probably not the solution. If they can live independently, then it should be the independent living pathway. If they need nursing home and the nursing home will not accept, it seems to me that it's something that should be brought to the highest level at the state.
And would others chime in on the chat box if you're finding this as well, so we can kind of gauge if this is a common issue of people being turned away? Sorry, go ahead, Megan.
I also, like, if there are questions here that really aren't appropriate for DHS, or not questions that DHS can answer and are kind of broader system questions, we will share those with our City Hall contacts and make sure that they are appropriately being heard. I don't want anyone to feel like we're just saying, oh, that's not DHS, end of story. We will make sure that we feed these questions sort of up the chain, so that making sure that others are aware of the challenges you are experiencing. We are not in any way trying to say like, oh, DHS, not our problem. We will feed those questions appropriately to other systems.
Thanks very much, that's appreciated. I've heard that home care and care coordination providers who are visiting patients in shelters, that many sites are currently very understaffed and that some of the clinical staff are working remotely. There is concern that healthcare access is severely hampered since many patients are difficult to contact. Can you speak more to this and whether there are plans to address staff shortage?
Fabienne, do you want to?
Go ahead, Meghan.
No, you go ahead.
Okay. So I guess it's two different questions really in one. There's a regular shelter staff and there is the clinical staff. Some of the clinical staff have told us that they work remotely, but they continue to provide the same services in evaluation that they provide, in person. If you know of a specific cases where that cause a problem, please feel free to let me know. We do know that a couple of clinics actually have told us that they cannot provide services because of staff shortage. Some of the staff were out sick. These have happened to mainly clinics that are providing services in shelter that we do not fund. We are very, the clinic that we fund, directly, we're very, very close contact with them, and we have told them that they cannot cut services. However, if they have a number of providers that are, out sick or cannot perform, there is only so much we can do. We will help ensure that the basic services are provided. It's the same with shelter staff. We have received, and Meghan probably can talk a little bit more about that in terms of reducing non-essential services, and we'll make sure that essential services, food and cleaning, security are always maintained.
Thanks. Yes, we've been evaluating sort of what at each shelter are essential services to make sure that our clients are safe and being properly cared for, but potentially reducing some of the services that in the past would have been done face-to-face, ILPs, things like that we are saying are not urgent in this current crisis that we're in. And so we are working with shelters to figure out what's the appropriate level of staff to make sure that we are keeping our clients safe and well cared for.
I understand that it was stated earlier that residents that are immunosuppressed are not appropriate for shelter. However, we do have residents with this condition in the shelter. What can we do to assist those residents in an effort to avoid possible exposure to this virus in the shelter system?
Well, they really shouldn't be in congregate. If they are in congregate setting, they really shouldn't be in congregate setting if they are severely immunosuppressed and they have a absolute neutrophil count of less than 500, or they have a CD4 count of less than 200. They technically should not be in shelter. If they are in a unit, if they are part of a family, if they are in a unit, then they are in their own private unit. We have instructed shelters and clients about social distancing and cleaning and staying 6 feet away as much as possible. If you have someone currently who is profoundly immunosuppressed and really should not be in shelter, but it is, I guess you can let me know and we'll look at it on a case-by-case basis.
Many homeless individuals and families have lost jobs as a result of COVID and are having a hard time meeting their families' needs. Are there any additional resources or benefits for these families at this time?
We encourage, go ahead, Fabienne.
No, go ahead.
We encourage families to work with their shelter staff and continuing to apply for benefits through our sister agency, HRA. I'd say really communicating really communicating with shelter staff when there are issues, and we will triage on a kind of case-by-case basis at this time, but encouraging everyone to continue to take advantage of the benefits that are available to them through HRA is the first step there.
So I know that we said that we weren't going to ask any OEM questions, but so we are going to try to have a whole session with them, but to the extent that you can, just give a basic overview of what the OEM room options are for non-DHS clients. There's any little bit of information you have, maybe more than others.
Sure. As I understand it, OEM has tiers of hotels. They are setting up hotels for healthcare workers that need to have isolated settings, as well as a hotel system for clients that are temporarily homeless. So someone who was living with roommates and cannot return to their home while they are currently symptomatic, but will be able to return home once their symptoms and go away. Those are really the target populations that OEM's hotel system will be created for at this time. I know that they are thinking about other potential populations, but I am not knowledgeable enough to speak to those. Also, my understanding of the OEM hotel system is that it is, while our system is limited services and limited wellness checks, their system has less services than ours. So, you know, they are really just providing meals and minimal healthcare checks for those sites.
So I know that this was partially covered before, but there's been another question. The turnaround time from the first call to a placement being identified is taking longer, sometimes spanning 2 or 3 ED shifts. We know that DHS staff are really busy with this surge, but are there any plans to increase capacity, and when will additional sites be opened?
Sure, yes, we are increasing capacity. We are on our 3rd round of issuing an RFP for emergency procurement of providers for isolation sites. If you or anyone you know wants to run an isolation site, please reach out to us and we will make sure that you get the emergency procurement and answer any questions you might have about running an isolation site. We are very much interested in working with providers to set up more isolation sites. We are actively soliciting about 500 more beds for isolation sites, but understand given the scope of this current crisis, we may need to add more. As Fabienne mentioned before, we are at about 500 beds. We have another site opening up this Friday. And so we are continually trying to expand our isolation capacity. We know what we have right now will not be enough, and we are trying to grow that.
And if I can add, you had a question on the hotline. My understanding is that the hotline is now fully staffed and the turnaround, the wait time should be less. So if the comment was about, you know, a few days ago or you know, before today, then that should be fixed. If it's something that happened that still happened and still today, please let us know.
Okay. And just in our last minute, I'm asking this in terms of your call for providers potentially interested in providing isolation sites. Do you have a basic kind of criteria of what you're looking for those sites?
So our RFP lays out very basics of what we're asking for in the isolation site. So it is food, it is some minimal social service staff on site, it's the medical care. The hotel rooms are actually being contracted and paid through OEM, so that's not a part of this solicitation. It really is the on-site services that we're looking for. But we will also be issuing guidance this week on some more specifics on how we think an isolation site should be run, which I think will give people a little bit more confidence in what we are asking when they are applying for this RFP. So that should be coming as well this week.
Great, thank you very much. And I know that we are now at the 1 o'clock hour, so we're going to wrap up. I know that there were some questions we didn't get to. I really encourage, some of the questions have been in about kind of transmission and how to protect staff and clients. And so for those folks, I really do encourage you to watch the town hall that we held last week with Dr. Lee Isaacson, because I think a lot of that stuff was addressed. And so we will be sure to share that around, and any other questions that we didn't get to, as I said, we'll be sharing those with DHS, and we will, once DHS has put together their FAQ, we will share that with all of you. We'll also share the guidance documents that have been mentioned, and please, the consortium will be hosting this webinar, the recording of this on our website, in addition to sending it out. And we also have different resources that are up there, so we will send the link to that. Please, if you have any more questions, you can email those to Harmony Arcilla. We have her email address. You know, we're trying to support you all the best that we can. I just want to thank all of you that are on the front lines and doing the best you can under extremely difficult circumstances. You know, you're doing wonderful work. We appreciate you and want to support you in any way we can. And thank you so much to our speakers, Meghan, Dr. Laraque, and Dr. Alessandra. Thank you so much for giving your time and answering all of these questions so thoroughly and well. I know it was a lot that we threw at you, so thanks very much, and have a great afternoon, everyone.
Bonnie, this is Amy Freeman from the Brooklyn Health and Housing Consortium. I just wanted to add, in case people didn't hear at the beginning of this call, we are trying to get someone from OEM to speak on a town hall as soon as we can get somebody, and we'll send out that information as soon as we're able to set that up.
Great.
Thank you again to our panelists. Do you guys, or speakers, do any of you have anything you weren't able to cover that you want to add before we close?
Thank you all for your. Go ahead, Fabienne.
I was just going to thank the hospitals and the providers out there in the community very much for the work that they do.
Yeah, same. Thank you all. We really appreciate it.
Okay, thanks everyone. Take care. Stay safe.
Bye.
Bye, everybody.